Those that are new to our webinars, the webinars are meant for patients, are meant for you to be educated about things we do with pain management. And so we've had multiple discussions over the last couple of months about different procedures, things that we can do for your back pain, implants, minimally invasive options for your spine. But I thought it would be helpful today to kind of, you know, go back to the basics and review, what do we look at when we look at the anatomy of the back? What does your back look like? What are the structures that are important to understand that could be contributing to your pain? And so maybe that would spark some conversations as to potential treatments and options, for you moving forward. And so, um, this video is recorded and will be on our website. And then certainly use the chat option to ask any questions. And then we'll save at the end, for any questions as well. And so, with kind of starting off is what do we know about the back, right? So the back is a structure that is really made to support our spine. And so, I like to tell my patients, I like to tell my providers, think of the back as an onion. And so we really want to peel different layers of the onion. So that top layer, that top skin layer is the skin and the tissue. And then you go a little bit deeper, then you have the muscle layer and the fascial layer. And then you go a little bit deeper, and then now you have the bone structure. And then you go a little deeper to that, and then you have the nerves and the, spinal cord and spinal canal, right? And so every different layer can contribute to pain. And so, when we look at the first layer, that kind of skin layer, right? You could have a rash that could be causing pain. You could have shingles that could be now driving some of that pain. Acute injury, falls, abrasions, right? Those can contribute to pain. And so, it's important to understand where that layer comes in. Now, where most of the patients do complain is that second, third, and fourth layer, and that second layer is now muscular, right? So muscle pain is true pain. Muscle pain can present itself acutely. It can also present itself chronically, right? And so we know muscles go up and down the whole spine. They can attach all the way at the neck and go all the way down to the bottom with regards to your lower back. And so any point along the way, that muscle can be strained. That muscle can develop what we call a trigger point or a tight, really knot. And what happens is that knot gets really tight. It can now limit your motion in that area. It can lead to more pain. And so once we look at the muscle layer, then we look deeper into the bones, right? The bones now house multiple structures. And so, if we have the little spinal model here, this is looking at some of the anatomy, and so specifically at the bones and the nerves, which is now what we want to talk about. And so this is the back of your body, this is the front of your body, looking at it at a side angle. And so what we have is you have the vertebral column or vertebral bodies, okay, and those are supposed to be thick enough to actually support your spine. And then in the back of the spine, we have different anatomical structures. This is your spinous process. You can sometimes even feel that on your back. And so these, again, protect your spine. These little joints here are called facet joints. And so they can be arthritic over time. And then in between the spine are these cushions called your discs. And the discs are there to support your spine when you're walking, sitting, moving. And so any of these structures, unfortunately, can lend itself to pathology, unfortunately, can wear and tear over time, unfortunately, can cause disease. And so, our job is to understand, hey, where is the pain coming from? And is that the pain generator? And so we talked about the skin, we talked about the muscle, we talked about the bone, and then finally the nerve. And so the nerve, as you can see here, is sitting inside the tube of the spinal cord. So this is the spinal cord, and it's housed by all that bony structure, right? So the spinal cord is very sensitive and a very important structure to help generate some of those pain signals up and down the spine. And so naturally, we want that structure to be very supported, and it's supported by all these bones around it. And so that spinal cord travels all the way from the neck all the way down to the tailbone. And then each segment along the way, there's these little nerves as they exit the spinal cord. And those spinal cord nerves are responsible for providing motor to your arms, motor to your other arm, motor to your abdomen, motor to your legs. They also are there to support the sensation to your fingertips, sensation to your legs, sensation to the rest of your body. And so understanding exactly where those nerves are corresponding to can be helpful in knowing that, okay, this is your pain. Your pain is going to your right arm. Now I know that this nerve is impinged, and where on the anatomy is it impinged? What bony landmark is pressing onto that nerve? And so again, the skin, the muscle, the bone, and the nerve really dictate where your pain is coming from. And certainly it can be a combination, right? We have many patients that have disc degeneration, wear and tear to the disc, but they've had it for years, and now the muscle pain is what's driving the pain. And so targeting our therapy towards that. And so this similar structure, even though this is showing of the lower spine, can be mimicked in the thoracic spine, can be mimicked in the cervical spine, right? So the anatomy is very reproducible. Even though everyone has, the way their body habit is, the way their, scoliosis is very different, but we know the anatomy should be similar. Every patient has, seven cervical vertebrae, 12 thoracic vertebrae, and five lumbar vertebrae, right? So that is pretty much anatomically similar among everybody. And so where the variation comes in is how the muscles are interplaying into that. How is the scoliosis or the arthritis in one patient worse than the other, right? And so that way we can kind of target our therapies to help in patients with back pain. Um, Now, briefly, that just kind of gives you a rundown of the back structure, right? It can be very complex. And so, how do we target our therapies, right? So we look at MRIs, we look at X-rays. And so, X-rays, can show the bone. And so what we see on X-ray is what I'm looking for is what is the height of this vertebral body? Is it this rectangular shape? Has there been now more compression onto the vertebral body? So what that's going to lend to is that's going to put more stress onto these joints in the back. When it compresses, that's going to put more stress onto the disc. And so that's what I'm looking at the X-ray. The X-ray is very helpful in that nature. The X-ray also shows me, is there a fracture? Is there a fracture in the bone here in the center? Is there a fracture in some of the bone here, right? It can also show me, is there any arthritis in some of these joints? So it basically gives me an idea that, hey, this could be driving some of the back pain. I see these things going on the image. Is this contributing to what you're feeling? What does an X-ray not show? An X-ray doesn't show me the nerves. It doesn't show me the disc. It doesn't show me the fat. It doesn't show me specifically where there's some narrowing of that space. And so that's why an MRI is very important in what we do, because now all of a sudden I can look at the back anatomy, and now I can get a very detailed picture as to where is that nerve impinged. What does a disc look like? Is it now minimally compressed, moderately compressed, severely compressed? Is there any atrophy in the muscles that could be contributing to the pain, right? So there's a lot of information that I can get from an MRI that I can't get from an X-ray. And so, obviously getting an MRI is useful in what we do. It's also useful to show you what's going on. It's useful to indicate, hey, is it intervention or injection indicated? Is surgery indicated? And so, part of the care plan is definitely getting an MRI, getting some imaging to understand the big picture as to what's going on. Um, Now we talk about how we treat back pain, right? From the most simplest form, there's really the conservative spectrum to the more invasive, right? And so most of our patients, we recommend the most conservative route, right? We want your body to naturally heal itself. Our job is to try to provide you tools so that the body can heal itself, right? And sometimes it takes going through physical therapy, right? What is the role of physical therapy? Physical therapy is not going to change the arthritis that's going on, right? But what it's going to do is help that first and second layer. It's going to help that muscle layer relax. It's going to help strengthen the muscles around the spine so that when you go lift, bend, and twist and do all these movements, this spinal column is well supported, right? Um, Maybe they're going to do massage. Maybe they're going to do ultrasound. Maybe they're going to do a TENS unit. Those are all controlling the superficial layers that we expect. Now, the benefit of that is it can reduce a lot of the pain. It can reduce that first layer, but unfortunately, physical therapy doesn't always get rid of that deep underlying arthritic pain, right? And so we have to understand that physical therapy over time can build the strength and muscles, but then at a certain point, you're still going to have some of that pain, right? So we need to understand how can we treat the deep rooted pathology. Um, Still talking about conservative route, chiropractor, right? Chiropractor in the right hands has a role. What does chiropractor do? Again, it can help realign the muscles, realign the structure so that it's not putting extra stress on your body. They can also do the massage and the modalities to, again, maintain that proper alignment so that the muscles have a chance to relax. Now, is chiropractor, an end all be all? No, it can be used in conjunction with the other modalities that we just talked about. Um, Conservative acupuncture. Acupuncture uses Chinese medicine to control different meridians or different pathways. Again, it helps control a lot of the superficial layers so that your muscles have a chance to relax and kind of, have a chance to recover. Then, next to that, we talk about medications, right? We use anti-inflammatory medicines to control inflammation at the area. We use muscle relaxers to help control muscle pain. We use, you know, um, different nerve agents to control nerve pain. We use other lidocaine patches to help control the topical layers. And then, other medicines like opioids down the line for that chronic pain, right? So again, it's important to understand where is the pain coming from and which medicine is helping that specific pathology, right? Most of the patients are on multimodal therapy, right? There's not, an anti-inflammatory medicine is not going to treat muscle pain. Same thing, a muscle relaxer is not going to treat inflammatory conditions. And so you have to use kind of conjunction medicine to treat where the problem is stemming from. And then, a bulk of what we do is we do interventions, right? So let's start from the basic interventions. The basic interventions are what's called trigger points. So trigger points are targeting the muscle layer, that second layer of pain. And so why are they helpful? They're helpful because they can actually pinpoint where that muscle knot is, release that knot so that now when you stretch, when you do physical therapy, that muscle stays into that normal formulation. It's not going to go back to that tight knot. And so we can do as much interventions as we can to the disc and the nerves and the joints, but if the muscle layer is still angry, we have to do that trigger point to release that muscle layer so that now we can uncover the underlying deeper tissue. And so part of your care plan might be involving doing that superficial layer, peeling that first layer of that onion and targeting those trigger points that might be developing in your muscle. And that's something that is just done in the office. It's done with local anesthetic. We put sometimes a little steroid to help reduce some inflammation along that nerve, along that muscle, and that can really improve your pain. Then we go now to the deeper structures, right? So now we're talking about the nerves and the discs and the joints. And so we do a treatment called medial branch block or, radiofrequency ablation. And so what we're doing is we're targeting these facet joints here in the back. And so what is a typical patient that has facet mediated pain? So that patient has arthritis that I see on X-ray and MRI. They complain of pain when they're standing or bending backwards. So think of it when you're cooking, doing dishes, standing for a long period of time at a concert or at the grocery store. What's going on is most likely these facet joints have worn down, right? We're not talking about disc, we're not talking about nerve right now. So those joints are driven of that pain. This is probably the most common cause of back pain. And so, like I said, pain with standing and extending backwards is driving that. And so what I do with my intervention is I actually target these joints. And so I put lidocaine around these joints. And what we're going to do is numb them temporarily. It's called a medial branch block. And so what that does is it numbs it. You're going to see for a day or two how much relief that gives you in your back pain. Now, if you get relief, it tells me that these joints are causing that back pain. And then we can subsequently do a treatment called ablation, where what we're doing now is not just numbing that nerve, we're actually heating that nerve to stop that signal so it doesn't cause pain. And so now this is providing 12 months of relief, if even longer. And so we haven't changed the arthritis. The bone has still worn down, but what we're doing is we're stopping that signal from saying, I feel pain, so that during that 12-month period, now you can exercise, you can strengthen the structures around the spine to reduce that pain. And so, one of the more common procedures we do in our practice, and that can be applied to the lumbar spine, the thoracic spine, and the cervical spine because the anatomy is the same. Now, let's talk about the second issue of pathology, right? The disc. We talked about the disc as providing cushion for our spine, right? When we sit, when we run, when we walk, we need that elastic support to withhold a lot of those forces. However, over time, that disc tends to be this size and then start to shrink. And then not only does it shrink, now it starts to what we call herniate. And so now it herniates into this round spinal canal to now pinch on the nerves. And that's when you might now have pain shooting down the arm, sciatica running down your leg, right? So no longer is it just back pain. Now it's back pain with some symptoms down the leg. And so that's where we have to gear what's called an epidural steroid injection. So that epidural steroid injection is not treating arthritis, it's now treating inflammation that's pinching that nerve. That disc is compressing that nerve, right? There's inflammatory markers all around it. So we really need to control that inflammation at that nerve segment. So that's why we do a targeted epidural under X-ray, and we're actually putting medicine around that nerve to calm it down. Sometimes it takes one injection and it takes care of all the pain. Sometimes it takes a subsequent treatment to really reduce that inflammation more if it's now become a chronic nature. And so again, the idea here is to get anywhere from 2 weeks to 3 months of relief in controlling that inflammation and pain. And so, now we are using that X-ray guided injection to target that disc and that nerve. After that, we talked about a lot of the other invasive, minimally invasive options, right? Now there's treatments to the SI joint, targeting joint and pain. There's the treatment called the mild procedure, which now we're not controlling just inflammation. Now we're opening up that space under X-ray to relieve that pressure. We can do ablation in the bone here. The bone here can cause pain. And so we can actually ablate a nerve here in the bone. We can do a treatment called spinal cord stimulation, where now we're controlling not just the anatomy, but we're controlling the pain signals that go up and down the spine. And so that can be a targeted therapy to control multi areas of pain. And so, again, very important for us as providers to talk to you, understand where your pain is coming from. Pain's very different from patient to patient. Look at your X-ray, look at your MRI, and really tease out. Look at that those layers, right? The superficial layer, the middle layer, the deeper layer, and figure out where is your pain coming from today. And so, again, I encourage you to discuss with your provider. Again, it's a multimodal approach. Maybe today it's your disc that's causing your pain, but tomorrow it could be your muscles and your nerves. And so, pain evolves, pain changes, and that's why the care plan can change over time. So hopefully that gives you a little bit of a brief overview of kind of the back and the anatomy and just structurally, how complex it can be. But more importantly, gives you some ideas as to what treatments we provide, why we do those treatments, and kind of stir up some conversation that you might have. And so, with that, I'll just want to end there with the talk on kind of options for your back pain, and leave it open to any questions.
Yes, question. I have had the spinal cord stimulator implanted permanently, just had it done. And the bandages have not been taken out yet, and the staples have not been taken out yet. And I was wondering if any further work needs to be done. Are sutures less painful than the staples?
Yes, yeah. So that's a good question. So you should definitely be having follow-up with our nursing staff to look at the dressings and change the dressings and take the staples out. So they'll be following you soon. But after that, I think you should be hopefully good to go as far as programming the stimulator. So um, just double check with my nursing staff. You should have a follow-up already scheduled.
Actually, yes. This later this week,
Yes.
Friday, I'll be having the staples taken out. Um, is How soon will I be able to work after that? Do you anticipate?
So you should be able to return to work, the following week. That shouldn't be a problem. But as far as once they get the programming installed and the therapy working for you, hopefully you should start, feeling better.
I'll tell you, the trial did show great promise,
Good. Good.
and so I look forward to having this pain go away after 40 years.
Yep, yep, exactly. And so kind of going back to the anatomy, the spinal cord stimulation, it's really geared to control those pain signals. So we talked about, the muscle pain, the nerve pain, the joint pain, all of that is coming to one central spinal canal, and that spinal canal travels up to the brain. So, when we have patients that have multiple areas of pain, right? They have nerve pain, they have muscle pain, joint pain, phantom pain, chronic back pain, post-surgical pain. It becomes very challenging to target our injections to specific areas, right? It might work for a temporary relief, but not a long-term relief because there's so many areas of pain. So that's when spinal cord stimulation really helps patients in that scenario because now we're controlling all those signals to where they converge. And so we're targeting that therapy and that relief. And so yeah, again, many patients in our practice do utilize that therapy. But from an anatomy perspective, hopefully you can understand, why we use that versus just an injection as to control some of the symptoms.
Well, the injections worked briefly, as you said, and as you said, they would. And Dr. Z is the doctor I've been working with, and it helped for a short term. The spinal cord stimulator trial helped for a longer term, and that's why we decided to go with the permanent.
Great,
And
great. Well,
so
all
it's
all
good.
the best. Yeah, no problem. Thank you, Peter. Are there any other questions from the group? You can feel free to chat or chime in.
If you've had a spinal cord stimulation implant and still having pain, can you have a radio frequency ablation?
Yes, very good question. So, absolutely, yes, you can have a radiofrequency ablation. You can have other injection treatments depending on what the condition is. And so, to your point, I'm glad you brought that up because the spinal cord stimulation is modulating pain, right? But now say you have a herniated disc, say you have, arthritis that's progressing. It might help, but it might not always help that acute pain, right? So certainly there's often a role for doing injections periodically to control that inflammation, control some of the arthritic pain, right? So think of it similar that you're taking medications to help kind of the day-to-day discomfort. If you have a long-term therapy like spinal cord stimulation, utilizing injections in the right fashion can help again optimize your pain levels. And so um, I think it's a good point. We want spinal cord stimulation to treat majority of the pain, but know that up and down you might have some issues that we can target those therapies. And so there's really no limitations onto any injection therapy we do, even if you've had a spinal cord stimulation in or even a back surgery. There's a lot of options that we can still provide from a conservative standpoint that might give you relief.
When you do spinal cord stimulation, do you do that with sedation or without?
Yes, great question. So we do it with sedation. Even for the trial, we do give sedation for the procedure. This is moderate sedation. It's IV sedation, so you're not under general anesthesia or intubation. So what that means is, for that 45-minute procedure, the recovery is a lot faster. The recovery is a lot better. So it's not an overnight stay. You're in our outpatient surgery center, and then back home within a half an hour or 45 minutes.
You use primary propofol?
Yes, we use a combination of a sedative, an anesthetic, a pain medicine. So that combination really gives the patients a lot of comfort.
Okay.
Yep. So Good question.
Dr. Mehta, do you recommend or do you use paddles or leads? I mean, what do you normally do with I just scheduled mine SCS for August the 20th because I have a litter of puppies now, but um, do you recommend that you use paddles or do you use just the leads? Or
Yeah, so
because I've
we
heard pros and cons.
yeah, great question. So we majority use percutaneous leads. The reason we use percutaneous lead is because we do it very similar to the trial. We want to mimic exactly what the trial experience is. And so what we do is
Hmm.
we, access just with those same needles, put the leads up, and then stitch those down. The benefit of that is twofold. One is less invasive. Number two, if we do need to revise the leads, if for any reason, if you need to replace them and adjust them, it can easily be done with the percutaneous system. And so it's very customizable in that respect. Now, paddle leads, where do paddle leads play a role? Paddle leads are mostly done by neurosurgeons, and it's done because what they do is they actually cut down the bone and they remove the bone. So they do what's called a laminectomy, and then they place a paddle. So that is a more
Mm,
invasive procedure,
okay.
obviously. A lot more
Okay.
recovery regarding that. The downside is that once you have it placed in, it can really be removed in a more invasive fashion. You can't adjust it if you need to. So um, typically, less than probably 2% of my patients get a paddle lead. The only reason I recommend a paddle is if a patient has a lot of scar tissue, a lot of surgical hardware that it is very challenging to get these percutaneous
Mm,
leads in. I do recommend that route, but even a lot of neurosurgeons are now choosing to do the percutaneous leads instead of paddle just because it's less invasive. It's easier for patients to recover and from that end. So, um, we've been doing paddle percutaneous leads for years and have not had issues regarding therapy and post-procedure outcomes.
okay. Yeah, because my 5 days of the trial were amazing, amazing, and I would have made the appointment to do the permanent the next week if I was able to, but I couldn't. So that's what I was hoping because I've heard pros and cons about the paddles and really not that good
Yeah.
of
Yeah, great,
information
great,
about the
great
paddles.
question. Great question.
Okay, now future MRIs. Do you? I mean, I don't know what kind I'm going to get. I'm sure you probably use a standard one. And do you use rechargeable batteries, and what do you do about future MRIs?
Yeah, so if MRIs, these are MRI compatible. It can be
Okay,
MRI conditional. You can turn it in MRI mode. So when you need an MRI
okay,
scan, you're able to do that. So that is not a problem
okay,
with any battery that we implant. Your
okay.
question about rechargeable or non-rechargeable, typically I favor the
Mhm.
non-rechargeable battery purely because it puts less burden on you as a patient. You don't have to worry about charging it on a regular basis, the battery going dead, and then now you don't have any therapy at all. So most of my patients, we implant the non-rechargeable battery. So it's a more of a set it and
Okay.
forget it type model, where you don't have to worry about
Good.
charging it. And that therapy can last you, 5 to 6 years, depending on the frequency of use.
Okay. Is that the smaller one or is it bigger?
So it's about the size of a cookie. So that's how I kind of
Okay.
describe it. Yes.
Okay.
Yeah.
Okay.
Good question.
Thank you.
Mhm.
I hate to ask all these questions, but it was what I was talking to Amy today, and I left a message for her. Uh, some I'm on the Abbott only Facebook page where you
Mhm.
ask, it's a group. It's really been very helpful. Um, but someone had said they were talking about bending over, and they said something about, well, talk to your doctor about adding extra lead lengths or something if you feel like you're going to be doing a lot of bending over. Does that make any sense, or is that something? Do you take into account the fact that you'll be bending over um,
Yeah, so
after
so never
after the
never
heal?
really a factor. I'm not sure where that what that patient was referring to, but typically the leads
Okay,
are very long. They're long enough that I actually have extra lead that I create little loops in. so that underneath the
Okay,
skin,
good.
so that when you bend and twist, it's not going to put more strain onto that lead. And so even my tallest patients, there's plenty of space to account for any mobility and any moving that you might need to do. So really not a factor as far as how I plan the case.
Okay, because with the Frenchies, I have to bend over and pick them up and set them on the table,
Yeah.
and they just mentioned something about right, you know. So
Yeah.
what's a typical recovery? What is the typical recovery
Yeah,
after
so
the
yeah,
SCS
so 10
surgery?
days, 7 to 10 days, you'll get the staples out. That allows those leads to fibrose and kind of get kind of honed in. And then after that, you should be on your way to recovery. You should be up and moving and ambulatory and kind of feeling yourself and back to your normal life. So not a lot of immediate, just that 7 to 10 days, I just recommend not a lot of lifting, bending, twisting. But after that, you should be pretty good.
Oh, okay, because I'd heard 2 to 3 months, and because I've got it 2 months after my surgery, I'll be driving to Vegas, so that's a 3-day drive out and a 3-day drive back.
Yeah,
And
no, not expected that long of a recovery. No, I mean, usually my
great,
patients even
great.
return to work after 10 to 12 days.
Oh wow. Okay. And here I thought I was going to be crippled for at least a month.
No,
Yeah. Not being able to lift or bend or twist or whatever. So okay, that's great.
no, not at all. Good, good.
Okay.
Any other questions from the group? Any other questions that I can answer for you about the anatomy, about different therapies, different injections we offer?
I have a question.
What exactly is arthritis, and is it something everyone's going to have with age?
Yeah, great question. So arthritis is basically joint wear and tear, right? And so the arthritic joints, whether it's your back joints, your shoulder, your knee, your hip, there's cartilage in between the joints, and that cartilage just wears down. And so when it wears down, it no longer has that cushion to support, and it starts to now what we call bone on bone or start to irritate and rub on each other. And so that's what arthritis is. Arthritis is a degenerative condition. So what does that mean? That means it can build up over time. It can worsen over time. Um, Genetics plays a huge role in arthritis. The amount of work that you do, your activity level plays a role in the progression of arthritis. Now, there's no cure, right? There's no cure for arthritis. We can't reverse the process, but we do have tools to reduce the pain for the arthritic joint. We have tools to support our structures around the arthritis to limit the pain, right? So I say that because just because, patient A has bone on bone arthritis doesn't mean that patient A has severe pain. And so, why do I see patients all the time that have the worst knee x-ray I've ever seen in my life, but they're now walking, they're running, they're biking, they're doing everything functional. And so it's important to differentiate that severe arthritis doesn't necessarily always correlate with pain. And so, knowing that you have it, knowing that it's contributed to pain is helpful because now we can identify how to treat it, how to prevent it from progressing, or how to prevent it from getting worse. But we certainly don't have a way to, cure it right now. We don't have a way to, just stop it from occurring or stop it from happening down the line.
Are all these treatments just masking the pain?
So, I say that yes and no. So some of the treatments like the epidurals, for example, they're powerful steroid medicines to control inflammation. So if you have inflammatory problem and we put medicine around that nerve to control inflammation, it might take care of it, it might get rid of it. When we talk about arthritis, like I said, there's no cure, but some of the treatments that we do provide can halt the pain to that joint, right? So in that case, no, it's putting a band-aid on the problem. It's limiting the pain for a certain period of time so that you can be more active during that period of time. But it is not changing the bone. It's not changing the arthritis. We talk about how do we go in and just change it, right? It's getting a replacement. It's getting a fusion surgery. It's getting a back surgery to cut away that bone that's, limiting that space. It's getting a knee replacement. You have a whole new knee, and you don't have that arthritis. So that might be a way to cure the problem, treat the problem, but again, what are the pros and cons of surgery, right? Are we better off of doing something conservative to limit pain so that you can be functional, or do we just go straight to surgery where we cut the bone out and now that arthritis is gone, but then what are the risk factors for after surgery? What are the complications for after surgery? Could that lend to other issues down the line? And so, that is the catch 22 that we kind of discuss with our patients. Is there a role for surgery? Absolutely, there's a role that we recommend. And then can we prevent surgery with other tools that we offer to help improve your function?
Thank you.
Perfect. Well, any last minute questions? Great. Well, again, I thank you all for joining. Again, applaud everyone for joining these calls and learning about your health and learning about your care. We'll continue this next month, so stay tuned to our newsletter to see what's coming up. Thank you for everyone's time.
Thank you so much, Dr. Mehta.
Yeah.
Thank you.
Bye-bye.